Well, a warm welcome to this talk. Thank you for logging on. I'm just delighted to introduce Emeritus Professor Robert Clancy from Sydney, Australia. That's right, isn't it? You're in Sydney at the moment.
I'm in Sydney, yes.
Yeah, that's right. Yeah, nice and warm. Yeah. Clinical immunologist, in fact, pioneering clinical immunologist. I believe you were one of the first. Well, were you the first senior clinical immunologist in Australia?
Well, there was no training program when I started. So 2 or 3 of us got together and said, look, let's make it something.
Right,
yeah,
okay.
So we were. That was at a time when the British were very laboratory orientated. You might remember with people like Ivan Lloyd, long time ago.
Yeah, but so you actually started doing it clinically. You're obviously a medical doctor.
Correct.
You've specialized in infections of the airway and the gut. And what I'd never heard of until I started preparing for this is the gut-lung axis, which I'd love to talk about later. You've developed a new vaccine in the mid-80s, was it, for acute bronchitis vaccine?
That's correct, yes.
Yep. You're a physician and a pathologist. How you managed to do that in one lifetime amuses me, but it's amazing. Your medical researcher, I did check 260 publications.
Is that right?
That is a lot more than me. Let's just leave it at that. Nearly 6,000 citations, which is amazing. Foundation chair in the University of Newcastle. That's obviously the one in Australia in pathology. A pioneer in the field of mucosal immunology, which I hope we're going to learn in this talk. You've developed treatments for COPD therapeutics. You're a doctor of science and, of course, a doctor of philosophy. And you've got the Order of Australia, the Order of Australia medal. I mean, if we went on, it would take up the whole talk. So thank you for coming. We're just delighted that you've come.
Great pleasure.
Thank you. So the first thing I'd like to talk about is COVID as a mucosal disease. And this idea of a mucosal compartment is kind of new to me. Could you sort of, what is the science behind that?
I think the best way to look at this, John, is to look at the fact that most people who do Immunology 101, and we all do a little bit of immunology, we're talking about the immunology that protects the body, that keeps all bacteria, all virus out of the bloodstream. And we call that systemic immunology. We read about IgG antibodies every day. But the reality is that COVID infection, like influenza, is an infection of the mucosal surface of the airways. And if we're good, we keep it there. And a very different type of immunology had to develop, because all of a sudden you've got a situation where there's lots of bacteria, lots of virus, very different to inside the body, which is completely sterile. And so you had to have an adaptation of this mucosal immunology, which did so quite separately. So you have these 2 compartments with very little crossover between them. And the greatest difference between the mucosal immunology is that you need a mechanism of downregulation, of suppression. Otherwise, you'd blow up with inflammatory response to all these bacteria and virus, which we now talk about as the microbiome. That's the essential difference.
I think I'm kind of getting it now. So the inside of the body is completely sterile. We almost have an internal immune system there. And,
Exactly.
and as you say, we know about the IgMs and the IgGs that are produced in response to antigens getting under the skin, as it were. But we've got this extra sort of immune system that's patrolling the surfaces of the body almost. So the mucous membranes, we're thinking about that lining the nose that produces the mucus, lining the pharynx, the airways. And because that's exposed to this milieu of infectious or potentially infectious agents outside, it needs its own separate immune system, really.
Exactly. And COVID, of course, is an infection of that compartment.
Right.
And the whole aim is to keep COVID there. If it starts leaking out down into the gas exchange part of the lung, which recruits the systemic immune response, that's when you get very sick. And a pandemic for flu or the coronaviruses is essentially when one of these viruses learns how to get out of that mucosal compartment and gets down into the gas exchange apparatus, recruiting what it doesn't want, which is this systemic immune response.
Right. So when I had flu, it started in my mucous membranes. I remember I had a really bad flu in 1990. I thought I was going to die. It was awful.
Yeah, I've been there.
And that's because the virus got from my upper airways down into my alveoli, where you're talking about tiny, tiny, thin, the lining of the alveoli, the endothelium, microscopically thin. The virus can get through that, and then when it gets through that and gets through the lining of the capillary, it's actually in the blood then, isn't it?
It can be, exactly. It can be.
And then the virus will go around the body, and that will generate a systemic inflammation. Is that the thinking?
That's essentially right. The COVID virus and the flu viruses can create all the problems most people get who get quite sick without actually disseminating through the rest of the body. That of course can occur, but that's a late phenomenon. That's in people who are seriously in hospital intensive care.
Yeah, but there's kind of a difference here, isn't there? There's the potential for the actual etiological organism or virus to get into the blood, and there's the potential for the immunological reaction of the body to that virus to cause a systemic inflammatory response syndrome, such as the acute respiratory distress syndrome, where the alveoli fill up with fluid. Am I right in thinking there's two ways to make you sick there?
What you're doing, John, is encapsulating the whole issue into the host-parasite relationship, the relationship between the parasite, which in COVID is a virus, and the host, which is the immune response. And it's that relationship and the outcome of that relationship that determines the outcome in that particular patient.
Indeed. So this mucosal immune system, just give us a bit of an idea of what are the components of it. I mean, I know immunoglobulin A's tend to live in the mucus as opposed to in the blood, but I'm not familiar with any sort of the cellular components of the immunity in the mucosal system. What sort of things are we talking about there? And are they innate? Are they specific? Are they acquired? Are they adaptive?
Yes, conceptually, there's no difference between the systemic and mucosal immune response. You have the generals, which are the smart people telling the immune response what to do, the T and the B lymphocytes, which most people have heard about. And then you have the foot soldiers who are recruited to do whatever the general tells them what to do. It's just that the generals and the foot soldiers are a little bit different at the mucosal end to the ones that are in the bloodstream and the spleen and the lymph nodes. The interesting thing about the airways is that it's an extraordinarily fascinating system whereby the lungs have one job, really, and that's to move oxygen into the body, carbon dioxide out. Anything that comes between or interferes with that action is a problem. And so the body has developed a system where it generates, the factories for developing these protection mechanisms are in the gut. And this is something that I think has been completely lost in the COVID story, is that when you get viruses and bacteria in the airways, it gets dumped into the gut all the time. You and I
swallowing.
We're swallowing a cup full of secretions every day and not knowing about it normally. It's only when you exceed that you start coughing something up. And so everything is getting dumped. And the factories that make the generals, the T cells and the B cells, for that mucosal immune system are in these little lymph nodes in the wall of the gut called Peyer's patches. And when I was a medical student, and when you were a student, John, the Peyer's patch was something you didn't have to know anything about because no one else did either.
Well, we had to memorize that they existed. I remember that
that gave you a high distinction.
For some biology exam or other. But these are actually lymphoid tissue, aren't they?
They're lymphoid tissue like a lymph node. And so the virus comes down and is taken into these in the upper part of the small bowel. And then the T cells and the B cells go and they've got little postage stamps saying, take me to the lungs. And so it specifically comes back to the lung to do the protection. And it generates the innate system, just as the IgG system. It's a slightly different innate system. And there's a lot of misinformation going around at the moment where people are saying, oh, look, in COVID, or vaccines, we're destroying the innate system. They completely forget the big picture, that what the innate system, if it's not there or there, it depends on whether the general's telling it to become organized. And so it's understanding that big picture that's so important in understanding COVID.
Wow. So the reason you get immunity to a respiratory infection is because you are swallowing the virus or the bacteria or whatever it is. That's recognized by these immune areas in the gastrointestinal tract. The cells in the gastrointestinal tract are then directed to the lungs where they generate the immune response.
Exactly.
That's incredible. I didn't know that. It's just amazing.
No, John, you're in good company when it comes to COVID.
It would appear so. It would appear so. There's been quite a lot of hot air over the past 2 years. It must have been almost intolerable for you to listen to the anti-science. I think we should just say that the reason I was so pleased to have you on is because, I mean, you do it at a completely different level to me, but we both believe in helping patients.
That's correct.
We both believe in applying science to do that. We both believe that science has to be accurate and has to represent some sort of truth and has to be empirical. And you've done that at a world-leading level, and all I've done is teach it for a few years. But I think we both.
Well, I think the other thing, John, is we're both keen on teaching it. We want people to share that knowledge.
Yeah, absolutely, very much so. So I'm getting this idea of COVID as a mucosal disease, and it's getting into it's becoming systemic via the gastrointestinal tract. Is that why was I so sick when I had influenza then? What actually triggered my sort of systemic inflammatory response syndrome to make me feel so bad?
What made you feel bad, and I ended up in Singapore hospital with the same thing, so I know what it's like, is extraordinary response of the body's immune system to the virus, basically getting out of where we'd like to keep it moving into where you can get a systemic immune response. Usually that means it's going through the conducting airways into the gas exchange, and so all of a sudden, the immune system switches from the mucosal response in the conducting airways to the systemic IgG type response.
The all-over full body system.
And you've got all these cytokines and molecules. That's what people focus on these days. They talk about without understanding how it fits into that big picture.
But that is true, is it? That my systemic immune cells will release pro-inflammatory cytokines.
Absolutely.
That will go to my brain, and that's a big part of what makes me feel so bad, isn't it?
Absolutely. And you can measure these in the blood.
Yeah. But there again, it's good that I feel bad in a way, because I'm going to lie on the floor groaning rather than go out exercising, hunting or farming or whatever. It's going to stimulate my heart and cause ventricular fibrillation or something like that. I mean, it does kind of make sense.
But yeah, it's an immobilizing.
Yeah, indeed. I was lying on the bedroom floor and couldn't get into bed. It was terrible.
I was giving a series of talks to the Southeast Asian physicians, and I wasn't there for 2 days. They found me lying on the floor trying to get to the shower. I mean, it's really a horrendous issue.
Yeah. And then you have other cytokines that generate fever. You'll have other cytokines that generate catabolism, to break down proteins, to mobilize, to make antibodies, and all this is part of the body's natural way of overcoming these potentially life-threatening infections.
That's right. I mean, cytokines are just very small molecules that are messengers going from the smarts to the less so smart and getting things to happen.
Yeah, it's quite amazing, isn't it? You could write a book on this, couldn't you?
People do.
Yeah. Right, now, the implications on this. Now, before I ask you this question, we want to notice in passing that you have personally developed a vaccine for treating acute bronchitis.
Now, what I did, John, was I was part of the first groups that were looking at how this system between the lung and the gut works. And it seemed to me that if we could get a large amount of bacteria and inactivate it and make that system of protection work optimally, then that would be a good thing. And that's what I developed. I just simply developed a way of enhancing and optimizing that protection, which is probably very valuable in people who are older, like me, maybe yourself, over 65.
Indeed.
That over 65, you turn off that immune response. And the reason that people get very sick over 65 is that they have a slow mounting of this immune response, allowing an expansive overreaction by the innate immune response. And so what I was doing was developing a way of shortening and making more efficient that process. And we were able to reduce hospitalisation by 50% in people with chronic lung disease. It was quite, but of course, no one's interested in it because it's such a simple, useless type of product. The pharma companies hated us.
Yeah, I noticed you said that's all you did. You just reduced acute hospitalizations by 50%. I'm impressed.
Well,
it's an interesting point, though, isn't it, here? Because the treatments that get globally diffused are those that can potentially have some return. We think of fellow Australian Dr. Barry Marshall, of course, with his Helicobacter pylori, which wasn't well received by pharmaceutical companies because he could actually cure people.
Yeah, well, I know Barry quite well. Don't feel too sorry for Barry.
Oh no, I'm not feeling. No, but he did have some early opposition. I remember that very well.
Yeah, I remember it very well. It was an incredible feat.
And of course, he experimented on himself, which was really quite mind-blowing. So my point is, you are able to look at vaccination objectively. So implications of the COVID as a mucosal compartment disease, what are the implications of this on the vaccine strategy as it's being practiced today?
Okay, well, when we began this talk, I emphasized that a major difference between mucosal and systemic immunity is the generation of suppression mechanisms aimed to suppress the inflammation that would otherwise blow up the body. Now, this is a story that goes back to a chap called Sulzberger and Chase back in pre-1950. It goes back to the whole area of oral tolerance for the pediatricians, wondering why people don't get sensitivity to foods, knowing that 2% of all the proteins we eat get into the bloodstream. And the body has developed this system where you downregulate response. And this is exactly what's been happening with COVID. All of us have been getting coronavirus infections over many years. Every time we get these infections, a little bit goes down into the gut, and you're stimulating not just an antibody, and we know that most people who get COVID have still got residual antibodies against the normal seasonal coronavirus, and they probably have a little bit of protection. But we also know that you're stimulating suppressor mechanisms. So it's all about a balance between the positive and the negative. And so all of us have in our lymph nodes, in our systemic immune system, existing immune responses that protect and immune responses that don't. And some of the early work that my group was involved in was showing that these are two sequential waves. Now, what we're seeing, and I think the best data is probably the British data, the Danes have shown something similar, you'd be very familiar with a lot of this, is that after about 6 months, and this is what a lot of people couldn't understand, the vaccines aren't working very well. And they're saying, oh, maybe it's Omicron or something like this. But in fact, the reality is you're starting to get this downregulation. And people are saying, well, wait a second, this is not like a measles vaccine. It's like a flu vaccine. And the flu is a very good analogy. What you see with flu, you're seeing with COVID. And the current situation of giving lots of fairly sort of panic reaction boosters is that we're starting to get a situation where we're getting a bit like food. We're getting a non-responsive systemic immune response. And this, of course, is the reason why we're starting to see in some countries more infections than we might expect. We're hopefully still getting the blunting of the serious because we're shifting away from serious to less serious infections. But the downregulation, and I think the concern is, I was just reading something about the fourth vaccine in Israel. You might have seen, John, that it looks as though they're getting antibody, but they have to be very careful. You can't relate antibody to protection. It's a surrogate parameter, something that helps you get an idea of sensitization, not necessarily protection. And so you have this situation whereby people are saying, wait a second, this is crazy. We're giving more and more vaccine, but we're getting less and less benefit. I think just looking at your own UK data from the first boosters, my reading is you're probably getting protection only for weeks, maybe a month or two.
Yeah, that's right.
And then you're back. And people say, wait a second, we got 6 months the first time. Now we're getting just a couple of months. What's going to happen when we have the next one and the next one? And so my driving compulsion is that we need to look at plan B. I'm an immunologist. I'm certainly a very keen vaccinator,
of course.
We need to do it scientifically, and we may need to bring in strategies with using widespread early treatments that are cheap and available, which I suspect I'm not allowed to talk about on this program, but we all know about them and we know how effective they are. And to me, that is where, but we're not getting this information transferred to the decision makers in the way in which I would like to see happen. I have never heard once anyone talk about why it is we're getting a turnoff of immune responses. And there's this whole precedent that it's not secret. It's all about the mucosal tolerance, this downregulation that you stimulate a positive, you stimulate a negative, and the balance determines what you see. Does that make sense to you?
It does. And this is exactly the data I was actually looking at yesterday, that with the first 2 doses of vaccine, you got a fairly good protection against symptomatic illness for about 20 weeks.
Yeah, exactly.
After the booster, it's down to 10 weeks.
That's right.
So presumably, if we extrapolate the graph, the 4th dose in Israel, we're probably looking at protection for only 5 weeks.
I think that's what they're seeing.
That's incredible. And the way I'd think about this is, of course, we have these lymphocytes in the blood. We have the large and the small. And the small ones, we've got the B and the T. But the T, we've got the 3 types, haven't we? We've got the T helper cells. We've got the T cytotoxic cells that directly kill virally infected cells. Yeah. We've also got the T suppressor cells.
That's right.
So what I hadn't realized, and this, I really appreciate this, what I hadn't realized is that vaccination can stimulate all 3 types of cells.
That's right. And I like to think of it even more simply, John, in saying that when you stimulate immunity, you're actually stimulating protection, suppression, facilitation of infection, and autoimmune responses against spike proteins represented through the body. So, and it's the balance of all of those at any time that will give you what you see. And that's exactly what we're starting to see. I think we've always been seeing in this infection.
Yeah, it's just that it hasn't been obvious till you've mentioned it today. This is the first time I've realized it. So when I eat peanuts, maybe 2% of that protein can get into my blood as peanut protein.
Exactly.
Then why on earth don't I make antibodies to that peanut protein? And therefore, next time the peanut antigen will interact with the peanut protein antibodies, and I'll get a severe allergic inflammatory reaction.
Well, yeah.
And it's is it the suppressor cells that's stopping that from happening?
Yes, it is. And in fact, we call that food allergy. Food allergies are where you don't get the balance right and you haven't learnt to suppress that response because you are getting small amounts of the peanut. Actually, it's a very good example because there's been some very good studies where a couple of years ago, someone said, well, wait a sec, if all this is true, if I feed peanuts to children who are high risk of developing peanut allergy, then I'm going to boost the suppressor component. And that's exactly what they did. Yeah. Getting back to an issue you just mentioned, which I think is concerning, is how long, if you build up with repeated injections, suppression, which makes you prone to COVID, how long does this last? And I was thinking about this last night, thinking you'd ask me that question.
How long does the suppression last?
But
how long does the suppression last?
How long does it? Thank you, John. Good question.
I was just about to ask that. Yeah.
Okay. Well, if you look at the peanut story, it can last years.
Oh, right.
Because what they do, they feed, the pediatricians fed these children, several hundred of them, twice a week, large amounts of peanut. And they built up a tolerance, so they didn't get food allergy. And when they challenged them a couple of years later, they still were not getting it. Now, there's a lot of reasons for this, but it suggests that we have to be extremely cautious about our vaccine strategy. And I think they got it right with flu more by accident than good measure by bringing in seasonal injections once a year.
So it is physiologically possible, is what we're saying, immunologically possible, that a vaccination could promote long-term suppression.
Yeah, absolutely, absolutely. And I think it's more than this, because every year we get coronaviruses, and we're stimulating this through the gut. And I suspect that's why we get the tolerance from after we have COVID, is that we're actually swallowing this, and it's going through this. Remember, we talked about how the machinery for developing immune responses in the airways is in the gut.
Yeah.
The machinery for developing the down regulation is also largely in the gut, and responds to the same specificity, same rules of immunization.
So why is it that, so I've been exposed to 4 natural coronaviruses on a regular basis.
That's right.
Why has exposure to those natural coronaviruses not down-regulated my immune response to them?
I think it probably has. And that's probably why you only get a very different antibody response, if you like, to a COVID injection than a measles injection. If you look at a measles injection or any other mumps or rubella, you get a big IgG antibody response, and then you give them another injection and you get a bigger one.
Yeah. Because
they're not subject to the same level of suppression as a mucosal immune response. It's that COVID starting off as a mucosal infection that determines and dominates the longer term outcome and influences everything we're seeing, whereas the measles goes through the blood and stimulates the systemic immune response first up.
Right. So the smallpox that's been eradicated, the measles, the mumps, all of those things, when they're injected into the body, the antigenic nature of that material is more likely to stimulate the T helper cells that are going to stimulate the B cells to produce antibodies, rather than stimulate proliferation of the T suppressor cells.
Yes, there aren't so many of the T suppressor cells there because
Got it. I think this is finally getting through into my learning difficulties here. It's the mucosal immune system has got to be like this, because we're exposed to every protein under the sun on a regular basis.
Otherwise, you'd blow up.
Otherwise, would be allergic to milk and eggs and cheese and basically every sort of protein that's out there, or every allergen that happened to breathe into my lungs, every pollen, which of course is protein.
Take that idea and you ask everybody watching this, what do you do when you have these? Oh, we have either desensitization injections or we give it under the tongue. And what that does, of course, is gradually increase your suppressor cells in the same way as having lots of injections. So there's an analogy between all of these observations.
So for desensitization therapy, it makes much more sense to actually give the material exposed to a mucus surface. And of
course is what's happening we've now moved. It used to be mumbo jumbo stuff. The ear, nose and throat doctor would grind up his house dust mite and drops under the tongue, and young academics like me would come along and say naughty, but of course it turned out to be right.
Yeah. No, right. So this is what I didn't understand: the fundamental difference between the systemic immune system and the am I right to say mucosal immune system? Is that a good way to describe it?
And the whole aim is to keep that virus in the airways where it can fly. And this, of course, is why you can have people with asymptomatic infection, lots of antibody in their blood from vaccination, but they can still transmit the disease because they're not subject to that systemic immune response. That only comes into play when the virus starts trying to get out of that mucosal compartment into the airway, into the gas exchange.
So it's quite possible to have lots of virus multiplying in my mucosa, some antibodies in my blood to it, but the antibodies not getting from the systemic compartment into the mucosal compartment. Therefore, I can still be infectious.
Exactly. There's a little bit of leakage, but you're absolutely right. And this explains why people who are vaccinated can still become asymptomatic or mildly infective and transmit the disease. Of course, exactly.
Yeah. So these T and B cells actually live in the mucus. Live under the mucus.
The lining of in the mucosal the lamina propria, the lining tissues of the of the airways and the gut.
And the B cells will sit there producing antibodies that actually diffuse into the lining mucus.
Exactly. And as you said, it's a different to the IgG in blood, it's an IgA. And that has IgG is a pro-inflammatory antibody, activates complement all the foot soldiers, whereas IgA doesn't do this. IgA acts all by itself to minimize inflammation. So you've got IgG pro-inflammatory, bring in the foot soldiers. IgA says, well, wait a second, I'll just bind to the virus and neutralize it, but I'm not going to activate all this complement and things.
Because it's localized to the surface.
Exactly.
Wow. That makes perfect sense when you say that. So what are the implications of this? What actually happens in sepsis when we get this cytokine storm?
Well, it's a very good example. There you've got invasion of the bloodstream, however it may come from the renal tract, wherever, and you get this massive systemic immune response. Remember, it cannot tolerate bacteria or virus in the air, in the blood. Yeah. And so you get this massive, exaggerated, unregulated, unsuppressed, no suppressor cells. And so you're pouring out the cytokines. And these cytokines, which are good in an appropriate place, in an appropriate amount, becomes incredibly damaging when they're just let loose. And so you've got this uncontrolled response, which you do not see in a mucosal. When you see it happening, which is going back to what we used to do, when you see it happening in the airways, the overreaction is coughing up yellow sputum. In people who have got chronic lung disease, they've nothing to do with systemic immunity. They get this inappropriate response, which becomes a little excessive, and they're just producing more white cells. And the more white cells go into make it look yellow, and they have an exacerbation of COPD. And that's what we were able to stop that by optimizing the protective mechanism.
Wow. Yeah, that is quite incredible. The importance of combining vaccine with early drug treatment. A bit of a controversial area, but I suppose we're probably not allowed to talk about particular drugs. But what is the difference between the prophylaxis that a vaccine will give and early treatment of the virus or early treatment of the inflammatory response that the virus is generating?
Yeah, I think these mustn't be looked at as separate. They work together. There's always going to be a role for vaccination, just as there is a very important role for early treatment. What the early treatment does, it reduces the load of virus. And if you think of virus in an unrestricted way, increasing the amount of virus, then clearly it's going to move outside of the bronchi into the gas exchange. It's going to activate a much greater response. And so to me, the only logical way of handling problems, and I'm not alone, of course, in this, is to help the vaccinators, and I'm a vaccinator, help the vaccinators come up with a logical strategy for vaccination by using early drug treatment, whatever's considered the most appropriate, early drug treatment, so that you, particularly with the Omicron, which I hope is a transit zone into seasonal infections, and some of us are thinking along those lines, that we help move towards spacing of vaccines so that we do not accumulate what downstream could be incredibly damaging. If we turn off, and we basically make coronavirus like eggs or house dust mite or something like this, so that we never make a response to it, and we may be in for really serious problems if we do that. And so I think we should be using, everyone should have at home their early diagnostic kit, their early treatment. It's so logical. We can do it in poorer countries, but we seem to have a problem doing it in our own. As you know, the politics better than I do.
Yeah. So the when doctors first get started, nurses and doctors started getting sick at the early starts of this pandemic, what I thought was they would get a very high inoculum, a high viral load. For example, if you're doing endotracheal suction, you could get massive aerosolization of the virus. The clinicians could breathe in a large number of viral particles, untold billions of viral particles. That would infect many millions and millions of their cells all at the same time. All of these cells would start producing viral particles all at the same time. So they'd end up with a very high viral load. That will get into the systemic immune compartment. And that's what could generate the really severe immunoglobulin G, pro-inflammatory cytokine, acute respiratory distress syndrome, and all those other sort of sepsis related things. That all falls in. Does that make sense? Does that fall?
Yeah, I think it makes sense. I mean, yes, it does make sense.
Yeah.
Whether that, I mean, there are so many variables here, John, in terms of determining that total load. I mean, it depends on the genetics, it depends on your previous sensitization, the particular experience, all of those sorts of things. But in general terms, of course, the greater the load, the greater the chance of getting significant infection.
So with Omicron, is Omicron intrinsically less likely to get down into the lungs? Because presumably if Omicron's up in the upper airways, we're still going to swallow it, aren't we?
Exactly.
So we're still going to get that sort of systemic effect because we've swallowed it and it's going into the Peyer's patches in the lungs. So why is it that if we're still swallowing the virus, that the Omicron is causing less, and I think we can say now Omicron is causing less severe disease? How does that sort of fit in with this thinking?
Oh, I think, John, that's the reason you and I and others are thinking that maybe this is a transit zone. We're seeing a mutant which has less capacity to escape from the mucosal compartment. And so the symptoms they're getting are local. They're getting cough, they're getting sputum, they're getting sore throat, but they're not getting that pro-inflammatory moving out of that passageway into the alveoli. They're not moving into that. And it may be, we know that one of the reasons that the early COVID variants got into the alveoli is because the receptor systems are more diffuse. There are more receptors in the alveoli, and so it's easier for them to go. It may be simply that the multiply mutated spike protein of Omicron is less capable of binding to receptors, and so therefore it's going to penetrate less distance. Maybe something as simple as that.
Yeah, but whatever the mechanism, we are seeing a much more mucosal compartment disease.
Yes, it's restricted to the
Yeah, because what I was confused about is that I was thinking if it's a mucosal compartment disease, then presumably it's not going to stimulate the systemic immune response. But I think you've answered that question now, because it still stimulates the mucosal.
Exactly. And what I didn't say before, which I should have, is that when it goes to these Peyer's patches, it's not just going to have cells directed back to the lung. Some of them have got IgG receptors on them. And so you'll populate all the lymphoid tissue to an extent. And that is why you get the systemic suppression. You've got the suppressor cells spread, and you need that when you think about the food allergy story. You need to make sure that you're not going to react to every egg you eat.
So you'll actually end up with these suppressor cells in the lymphoid tissue in your armpits and your groins.
Exactly.
Whether
it's Omicron, whether it's Delta, whether it's Alpha. Exactly.
Wow. Yeah, incredible. So, but the moral of the third question there really on the early treatment was that the lower we can make the viral load, the better.
Exactly.
And as well as that, some early treatment drugs could be limiting the immunological response. Should the inflammatory response exceed the suppressor response?
Exactly.
Early treatment could prevent that and therefore prevent some of the inflammation. So there's really two ways to attack this disease: attack the virus directly and attack the pro-inflammatory response of this virus, and both of those can be done with the appropriate early treatment therapies.
Yes, and by combining the vaccine strategy with the early treatment strategy, I think we're going to be very quickly, I would like to think we're very quickly out of the terrible situation we're in at the moment.
So this is a synergistic approach to medicine, isn't it?
It is.
The vaccine and the early treatments.
Unfortunately, there are not a lot of synergistic people involved in making the decisions, it seems.
Well, I'm hoping there's going to be a few more after, if a few people watch this video, will be the hope. Now, these vaccines that we're using now, we could call them genetic vaccines, whether it's the adenovirus vector DNA vaccine or whether it's the mRNA vaccines. They're both genetic vaccines, essentially. Do you think we're missing an opportunity here by not exploring classic antigen vaccines that maybe generate a much more polyclonal response?
Yeah, well, my views on this are very clear, that the genetic vaccines, which is a term I also use, genetic vaccines produce unregulated amount of antigen in the body. You have no idea how much. We know it circulates in blood for several weeks, maybe in microparticles for a lot longer. We know it's represented throughout the body. It's appearing in all sorts of tissues. Post-mortem studies of people dying up post-vaccination are showing the spike protein in the lesions in the blood vessels. So we know this. One of the things I was thinking about also last night was that maybe with the vaccines, because we're expressing unlimited amounts of antigen, maybe we're also swallowing some vaccine, some of the spike proteins, and that's affecting tolerance. I don't know, but I don't think it's been looked at. But the reality is that we have absolutely no idea how much antigen's in the body, what it's doing to our immune response. And it'll be very, very interesting to see as Novavax and some of these protein-based, antigen-based vaccines, as we start getting experience, are we going to run into the same level of immune non-responsiveness that we're seeing now with all the genetic vaccines? We don't know the answer to that. I don't think it'll probably make too much difference to that, because I think that's, but it might. I'd like to think it might, but I don't think it will.
But if you're giving a protein-based vaccine, you're giving a precisely measured dose of antigen, aren't you?
Tiny little weeny bit of antigen, exactly.
And you know exactly how much, and the body's not going to make more of that antigen.
Exactly, and it's going to be pretty much limited to the lymphoid tissue, although it spreads a bit, but not much. Exactly.
So, as we've said, spike protein has been found in the endothelium of blood vessels.
Exactly.
Does that mean, do you think, that the recipe, if you like, the adenovirus vector or the RNA microparticles got into the blood, migrated into the cellular endothelium, and the vaccine stimulated the protein producing mechanisms in the vascular endothelial cell?
I think that's the logical understanding, but we're at early days. We know so little about these vaccines. I know it's very trendy and whatever, but people forget that when we had the 57 and the 68 flu pandemics, they made traditional vaccines within 5 months. 5 months of those, the appearance of those novel mutants. And so the argument that, we've got big advantage with messenger RNA vaccines, it really doesn't hold as strongly as the big companies would like us believe. I'm very concerned about the genetic vaccines. There's a recent study where they tried to make a flu vaccine with a messenger RNA, which you might have seen, and it was no different in outcome in antibody production than the traditional one. So I think that we really have a lot of work to do if we're going to start immortalizing messenger RNA vaccines in our medical armory.
I mean, it sounds like a very useful potential tool in the toolbox, if you like, but not necessarily the only tool we'd like to use. I didn't know that in 1957 they produced vaccines in 5 months.
Yeah, they did, and in 68.
And in 68, that is incredible. Yeah. The interesting story, in late 1957, my mum was so sick when I was a baby. She couldn't get out of bed, and my gran came and took me away.
I know.
She wrapped me in the plaid and she took me away when I was 5 months old, I think I was. And
yeah, it makes me a little older than you, John, but I remember in the...
But both my parents were so sick, they couldn't look after me. You know, it was...
Oh, it was the mortality. It's interesting going back and look, the mortality was 0.5% in back then.
Yeah.
And that mortality is greater than we're seeing with the Omicron variant.
Yes. Yes. Yeah. Yes. Absolutely. Yeah. Yeah. So in 1957, they cultured up a load of viruses using some sort of cell culture. Was it maybe in eggs or something? I don't know.
Yeah, kidney cells, monkey kidneys. Yeah.
Oh, that's right. That's been around for a while. Yeah. So the culture of those up, produced untold billions of viruses, attenuated those viruses, and just injected the virus.
Well, they were using eggs for that. They were still using eggs.
Oh, I thought right. Okay. Right. Right. But basically, they took the virus. They bred up the virus in eggs. They killed the virus, simply injected the whole virus, the whole dead virus.
Exactly, just like some of the vaccines around today for COVID.
And yet today, everyone's mouthing off because we produced a vaccine in what? 10
months.
It was more than 5 months, wasn't it? I mean,
it was more than.
We didn't get the first vaccines till what was it? December.
That's right.
December 2020. So that's basically the best part of a year.
That's right.
So in the last 64 years, we've learned how to make vaccines twice as slowly.
You're becoming a cynic, John.
Oh, surely not. It is interesting. Interestingly, though, the Chinese vaccine was an attenuated or killed.
Well, that's right. I don't know a lot about it, but my understanding is it's an inactivated virus vaccine.
Yeah.
And that, I think, appeared before the messenger RNA ones, didn't it?
Oh, yes, absolutely. I mean,
Sinovac or something, yeah.
Yes, it's Sinovac, that's right. Now, the other thing that's interesting is that the adenovirus vector vaccines, obviously the adenoviruses are virus size, of course, but the microparticulates that they wrap the messenger RNA in are also viral size. And my understanding is that the body reacts to the physical size of these particles in the blood. Because if you have a virus, if you have a particle of a particular physical size, the body thinks that's a virus. And therefore you can get an inflammatory response to it. So my question is, and you probably know this is one of my hobby horses, if you had a larger intravascular dose of adenovirus vector or RNA vaccine, is that more likely to cause a potential systemic effect because you're getting a large dose of the vaccine going directly into the bloodstream?
Yeah, I think the danger would be the level of sensitization at the time you give it. I mean, it's a bit like any intravenous antigen. If you give that and the person's sensitized, you can get anaphylaxis very quickly. But having said that, look, I don't know the answer to that question. I'm fully aware that particle size and the way in which whether it's got a lipid that will actually get into cells more easily, which is what they're trying to design all the time, the level of intrinsic adjuvant that make it work better. All of these things come together. And of course, vaccinology is a pretty sloppy science, with great respect to my colleagues who make these, that, because there are so many variables. And to try to dissect out the variables, and then you do it in a mouse, and you say, well, is the mouse the same as man? And so there's a lot of empiricism, I think, that comes in vaccinology. And of course, we all love modern technology. I can remember when my son left home, technology walked out the door. You probably had the same experience. And here we are using all this technology, but it's when you look at vaccines, some of the best vaccines are some of the crudest of vaccines. You go back to what we still give our grandchildren, and they're getting the same vaccine that I had when I was that age. Tetanus toxoid, or we've improved a few like whooping cough, but by and large, it's pretty basically the same.
We give it every day on A&E. I worked for 3 years part-time on A&E when I retired from education, and I must have given, I don't know, probably average 3 or 4 a day, tetanus toxoid injections.
Of course.
So my point I'm trying to get at there is, do you think there is some merit in advising aspiration to prevent inadvertent intravascular administration?
Well,
I know it's not in the.
I think it would be a brave person to go past the suggestion stage. I mean, I think you're very keen on aspiration for immunisation, aren't you?
Well, I think that even in the deltoid, where it's less likely, that there's about a 1 chance in every 2,000 or 3,000 injections that you could give an intravascular injection.
But if you're doing that, we have evidence that people are getting more side effects from the vaccine. So, I mean, I would think that you have to have a very balanced approach and think it through. I understand the theory of what you're saying,
sure,
but I think that there are practical issues that might make that a difficult. Well, there you are, John. It's a new company you can start.
No, I don't think so.
Probably not.
I mean, I trained student nurses for, full time for 27 years and, another 15 years on top of that. And I always said you stick the needle in and you draw it back. And, to see people not do that, I kind of find it difficult.
Now here you're saying, let's put it directly into the vein.
I'd rather not do that. I'd rather put it into the muscle where it's going to go into the cells to generate the antigen, so that the antigen generates the immune response in the arm.
Exactly.
And we're not getting expression of spike protein, say, from the myocardium, which would then attract an inflammatory response to the myocardium, which we certainly do not want.
We do not.
Yeah,
we certainly do not.
Yeah. Can just a quick question that would help my thinking here. How does colostrum play into this mucosal immunity when the baby's first born and the colostrum for the first few days?
That's really interesting because I just saw the other day a study on breast milk that you might have seen, where there was no evidence of, I think, virus in the colostrum. But if you looked at antibodies, I bet you pounds to peanuts that you would find antibody, because colostrum, what we didn't go into was how I got into mucosal immunology with John Bienenstock in Canada at McMaster University. John came up with the idea that there was a common system between all the mucosal surfaces. And that's how my entry point was injecting the rabbits, I think. Yeah. But what we showed was that the cells that come from the Payas patch with the postage stamps, the postage stamp says go to the airways, but it also says go to the reproductive system, go to the gut, so you've got this system and go to the colostrum, go to the ducts in the breast for the, and this is the way the baby can actually get some of these antibodies that they would like to get. This is why one of the many reasons why breastfeeding is so important.
Yeah, that's amazing. So there's actually a chemical signal in these cells, in the Payas patches in the gut, that literally tells that cell to go to a particular tissue.
Yes, it puts a receptor. It puts a binding protein that will go to any tissue that has the right receptor. It's a docking system.
Yeah.
And so you can see here's the Payas patch, and out comes the T cell and the B cell, and it might say, hey, take me to the lymph nodes and I'll have a systemic immune response. Yeah. But it might say, take me to the all the mucosal tissues, the breast, the respiratory tract, the upper respiratory tract, the gut, and we'll protect. And so the ones that have the postage stamp going to the breast will make an IgA antibody. The ones that have the postage stamp taking to the lymph nodes will have IgG antibody.
So these are different ligands essentially that must be made to fit a particular receptor that is specific to a particular tissue.
Exactly.
Yeah.
Exactly.
Isn't the body amazing? It's just incredible. Just incredible. Do you think in the States, for example, there's only a 3-week gap between the primary and the secondary dose? Would your intuition that could be a bit longer?
Yeah, I think that's a panic reaction. It's a concerning panic reaction. And it's because they do not have people that really understand. I won't go into personality, but I actually know a lot of these guys for many, many years. And their understanding of immunology is very different to yours and mine now.
Well, I wouldn't
different.
compare your understanding and mine by any means at all, but it's interesting that you get people in these very senior positions who don't really seem to understand the required basic science.
I'll tell you some stories off camera.
Yeah. Is there any you can tell us on camera? Probably not. Probably leave that one.
No,
we'll leave that one. My apologies for trying to be provocative. I think that's answered most of my main questions, actually, Robert. I mean, it's just, whenever I do these talks with people, people that actually know the field like you, and my mind's just reeling with the just amazing nature of the science we've been talking about, and it just takes me a while to sort of come down after that. It's just
well, I think in this area, John,
incredible.
This is not rocket science. It's not new, but I think it's been sequestered away from the people who are working in COVID. If you talk to some of the pediatricians interested in food allergy, they'll tell you the same story. And it's just a matter of taking that basic science, which has been around for probably 80 or 90 years, in a very primitive form, and adapting it to what's going on in COVID.
Mm-hmm. And to a large extent, let's just say that hasn't been happening to the extent we would like.
Sadly, not.
Yeah. How have you been personally, Robert? Have you had Omicron's rampant there at the moment? Have you kept well?
Well, with a bit of luck, we're sort of hit the peak and it's on the way down. All my family seem to have. My daughter rang last night to say she thinks she's got it. My son's just got over it. We've had a lot in this environment. Christine and I haven't had it, but it's. In many ways, I thought I had it, and I was terribly disappointed to find when I looked for the nuclear capsid antibody, it was negative.
Right, okay. Yeah, the specific antibody, okay. But it is inevitable. I mean, I was very surprised if you hadn't been exposed to it.
Oh, I think you're right. Absolutely right.
Thankfully, your immune system.
We've got a delayed response here. I think we had a pretty sort of pretty rigorous lockdown process in Australia.
Oh, very, yeah.
And it's been very destructive economically and psychologically. But what I think we're seeing is a bit of catch up. We have one part of Australia called Western Australia where I hate to think what's going to happen over there. I just noticed today they're starting to get increasing numbers.
There is a little bit of community transmission now in Perth, I think, but
just a little bit. Yeah, it's just starting to happen.
I would imagine that there will be an exponential growth over the next few weeks, and we get a very similar curve to the curve you've just seen in Victoria and New South Wales.
That's right. I guess in a sense, those who make these decisions would say, okay, we're getting this a delayed response, but we're getting it with a less pathogenic organism. Yes. I guess that's one argument they can make.
Isn't it fortunate that Omicron is less pathogenic than Delta?
But I think that's it's not surprising, John. I mean, if you look at every pandemic we've had, certainly in my part of the world, right from the bubonic plague in 1900, right through all the flu ones, they're basically all over within 2 to 3 years, every one of them. And it's because, to me, a question becomes: have we distorted that natural sort of resolution of a pandemic by what we've been doing in treatment, the way in which we've been vaccinating? I don't know. Are we delaying our move for natural immunity, which we're starting now to see throughout the Western world and much of the non-Western world, which we know is better than the immunity that follows a vaccine?
Yeah, I mean, my thinking is that I'm going to be exposed to Omicron. There's maybe 20, 25 antigens are going to generate an immunological response that'll affect my antibodies, my B and T cells. I'm expecting that's going to give what I now understand as my mucosal immune system one heck of a boost.
Exactly.
And I'm going to be, and because it's so polyclonal, I'm expecting that I'm going to enjoy immunity to a wide variety of possible future.
Well, I think that's exactly happening. It's my understanding is that those who have had Omicron have significant immunological protection against Delta, and some of the earlier ones.
The evidence for that is pretty strong now, because of this massive polyclonal response. So Delta's probably the best thing that could have happened to the human. Omicron is probably the best thing that could have happened to the human race.
That's my thought. I'm not saying it's the best thing, but it's certainly, I think, a good thing.
Yeah, sure. It's the least bad thing that could have happened.
Yeah, as I said earlier, I think it's the transit zone into seasonal. We're going to have seasonal corona in a more pronounced way, I think, than we did.
Yeah.
And the clever vaccine companies are already producing combined flu and coronavirus vaccines.
Yeah. Well, I've actually been telling people on videos that this is probably a natural form of immunity, and it's the best thing that could have.
Have you? Okay.
Compared to Delta, so I'm relieved to see that you at least partially agree with me, which is quite.
I think there are a few people in hospital that may not agree with us, but then you look at the amount in the community, certainly here, and you look at the hospitalisation and the people who get into intensive care and die. It's so much different to what it was, the ratio. And if we could only have available early treatment, it would accelerate our move through this and save lives. And don't get me started.
As indeed we have for bacterial infections, for example.
Exactly.
The bubonic plague, not many people know about the bubonic plague in 1900. But
my wife in the background is saying, and shingles.
Oh, yeah. Shingles is herpes zoster virus, isn't it?
That's right, yes.
So vaccine for that.
Well, there's a vaccine for that, but there's also early treatment.
Yes, absolutely, yeah. The antiviral treatments, and that can prevent horrible things like the lancinating facial neuralgias and hideous, painful conditions. Excellent point. Yeah. I mean, not many people know there's a bubonic plague outbreak, and was it confined to Australia in 1900? No.
It was the third great pandemic.
It was all over in 1900.
Came out of exactly the same part of China that the current COVID has come out of.
Yeah.
And it came for the first time to the New Worlds, the America and Australia. We had 400 cases in 1900. And John, I'll just give you one really, really interesting trivia. The idea of test and isolate began with an amazing guy called Ashburton Thompson, who was head of medicine in Sydney at the time. And what he did, he tested every rat in Darling Harbour, which is part of Sydney. And when the rats started appearing to have positive, he then isolated them in a rather permanent way and stopped the pandemic.
Wow. So
test and treat, isolate, test and isolate really began with the pandemic.
Amazing. And of course, when bubonic or pneumonic plague arises now, we can just treat it with antibiotics, and that stops the spread.
Exactly. And I think Australia is it's the only continent that does not have bubonic plague in its native fauna.
Oh, is that right?
Yeah.
Okay. So it's enzoonotic in these other areas.
Yeah. You still see it in America. You certainly see it in Southeast Asia, occasionally in Europe.
Yeah.
The Black Death appears.
But it's the early treatment that stops it.
Early treatment.
The early treatment analogy there is.
You have to diagnose it. But once you do it, the antibiotics are good.
Yeah, as long as you think of it, it's
But it's like every part of medicine, you've got to think of it.
You've got to think of it first. Yeah. Robert, thank you so much. I know it's your side. Have you had breakfast yet?
I have.
Oh, that's okay then. Right.
We're normally walking through our botanic gardens at this stage. So
right. Well, thank you for your time. Thank your wife very much for your time as well. And
my wife and my daughter are serious follows of yours, John. So
I'm delighted and humbled, Robert. Thank you. Thank you. Yeah. So let's do look at the comments. I'm sure there's going to be many very positive ones. And
you have comments, do you? Okay.
I get thousands. Yeah. If you look through, I'm just hoping everything's recorded properly, because I'm not very good at this kind of thing. But
go on.
As you say, I normally get my son to do everything, but he's a few thousand miles away. In fact, he's closer to you than he is to me. A lot closer. Great, Robert. Thank you very much. And
great pleasure.
Really has been a pleasure and an honor, really talking to you. And I've learned so much. just brilliant. My mind's just boggling with it. I'm going to have to go around make some notes on it or something. But yeah, thank you. So I'm going to stop recording now, I think. Recording.